Appreciate all of you being here. I really want to take this opportunity to speak with you today about something that has really been a big part of my life, both personally and professionally. You know, in some ways, my career has been bookended by two pandemics, HIV on one end and now the COVID epidemic, although I'm not done with my work yet, so it's not totally bookended. But it's taught me a great deal that I'm hoping to share a little bit with you today. I'm going to share mostly graphics with you as I frame our discussion going forward, hopefully with some time for questions and comments. I've asked Evan if he'd be willing to peruse the chat as it appears, so that if you have questions that you don't want to lose track of, just type them into the chat. We'll try to come back to them and collect them and get to as many as we can. But I'm going to focus our discussion a lot on history and then where we have come from, where we are, and what you as physicians need to know about HIV. Okay, I'm still, there we go. So why is history important? This is George Santayana. Some of you have heard about him as a philosopher, historian. He's the one who famously quoted or stated, "Those who cannot remember the past are condemned to repeat it," 1905. I think it's one thing to remember, it's another thing to intentionally ignore or to fabricate a different truth about the past. And so I really want you to think about, why is history so important in the details? And let me give you a concrete example. During the height of the AIDS epidemic, we were very concerned about not harming people by asking certain intrusive questions that they would misinterpret. Like, you know, how did you get it? How did you get HIV? Seemed really intrusive and difficult. And so people shied away from how to enter into that discussion. On the other hand, as a psychiatrist and a doctor, I really wanted to know what was the route of transmission, because it affected how they felt, how they thought, and also what were the stakes and how were we going to proceed, especially if I was working with somebody in psychotherapy. So that if somebody got it from sexual behavior, I needed to be able to talk with them about their sexual behavior. If somebody got it from using IV drugs, I needed to talk with them about their IV drug use. So it's easy to take a position based on a feeling like, I don't want to hurt anybody. It's another thing to not really delve into the details of things in a compassionate and kind way, which I think is really what most people are afraid of. Let me see, there we go. Okay, I got this down. So many of you weren't even born when this probably came out, but this was startling in the public eye. And at one point during the early days of the epidemic, AIDS was on the front page almost continuously on every periodical across the nation. When was the last time you saw it as a front page story? When did you see it as a page 10 story? You know, we've been slowly acclimating to the fact that this virus still exists in our culture, in our civilization. And although we've made incredible progress in AIDS, much of which is helping us to understand the kind of progress we've made, in fact, with COVID, the worldwide impact of HIV still continues to be devastating for many, many people, because it still has affected almost every institution in every country because of the lack of people alive to do work, to pay taxes, to do all sorts of things, as well as just the plain human suffering involved with that. It's also brought out, however, the best of our humanity and the way in which we have banded together as human beings to try to solve this problem worldwide across the political spectrum of things. So as you know, the first cases were discovered and put into the literature in about 1981. And I'm going to give you a timeline with some things, with some personal references here. This is an intensely personal epidemic for me. I was an intern in San Francisco in 1980 to 81. I moved out there from quiet, tranquil Vermont, where we hadn't heard about AIDS. In fact, most of the world hadn't, except for the epicenters like San Francisco first, and then New York, and then LA. But you know, in 1981, about 10% of the gay men in San Francisco were already infected with HIV without knowing it. Now, how do we know that? many of you may not have known that there was a study going on looking at the epidemiology of hepatitis B. And so thousands of gay men in San Francisco who were sexually active, which is a route of transmission for Hep B, had donated blood, and it had been banked so they could study the epidemiology over time of hepatitis B. Once the virus was detected for HIV, they were able to go back to those blood bank samples and see what percentage of people who had banked blood were already infected. Pretty smart. That's where we get the notion that 10 to 12% of the gay male community in San Francisco. Now, that doesn't represent 12% of the world population. That represents a very particular population, and we should keep that in mind. But for those people who then became symptomatic in 1981, they got ill based on something that they had no idea they were facing. It's like being hit in the back of the head with a bat and wondering what happened. And in fact, it was a different generation of gay men at that point, because these were mostly working, affluent gay men, many of whom had serious medical problems too, of other kinds, drug use, but they were people who basically were functioning in their lives, suddenly being told that they had a lethal terminal disease, because at that point, there were no treatments for HIV. And to give you an example of the denial that set in even in the gay community about how this might be transmitted, a lot of us in the medical community felt like it looked like a duck, it walked like a duck, it quacked like a duck, it was probably a duck, meaning we thought it was a virus, and we thought it was sexually transmitted because of the sheer epidemiology. If, like the flu, it was casually transmitted, there would have been millions of people infected over the next 2 years of 1981 to 4. Okay, so many of us took the position of, well, we don't know what's causing it, but we do know how it might be transmitted. What can we do to forestall the transmission? How can we help people with prevention and education? Now, I happened to be in Boston as a resident at that time. 1981, I moved back to Boston to start my residency at Mass General. And I was part of a gay psychiatry, gay physicians group in Boston. And we really went out of our way to try to educate the gay community that had worked so hard to win its liberation and freedom sexually after so many years of being in the closet and oppressed and prejudiced. And as you know, the gay liberation movement, which dates pretty much in people's eyes to the Stonewall Revolution of 1969, really had been going on through the 60s with all sorts of sexual liberation in all communities. That was really coming to a head. And by the time this virus hit, it was the perfect vehicle for elaboration and transmission. If I were a virus, this was the smartest move I could have made, to be transmitted sexually or with IV drug use. Now, I was actually part of a panel at Faneuil Hall, one of the oldest institutions in the United States where the Constitution was discussed in Boston. And I was part of a group of men who was dying of AIDS, an internal medicine doc, and myself as a resident. And we were saying to the 1,000 people who showed up for this meeting about how we might be able to protect ourselves by using condoms, avoiding certain kinds of more intrusive sexual behaviors, at least for the moment until we got a handle on this epidemic. And we were all being sex positive, but cautious. Well, there was a journal in Boston at the time called Fag Rag, which, as you can imagine, was a very radical anti-establishment magazine. And they wrote this discussion up, and they called me a sex-negative Nazi, actually. After all the years that I'd been teaching positive attitudes toward sexuality, I actually found this quite amusing. But it spoke to the denial that the community had about, don't take away from us what we worked so hard to get. And you can identify with that. When people have struggled for freedom and liberation, and you tell them to stop it for a while, imagine what it's like to take that in and metabolize it. And remember, people were scared. They had no idea what we were dealing with, but it was growing tremendously by that time. So think about this explosion. By 1984 and 85, with the discovery of the virus, by this time, the virus had been called several things. First one was the gay immune deficiency syndrome, blaming it on homosexuality. The second nomenclature was the 4-H club: homosexuals, Haitians, heroin users, and hemophiliacs, grouping people. And the purpose of that in people's eyes was, I'm not one of them, I must be safe. Okay. Then we moved into what was called lymphadenopathy syndrome, then HTLV3, which was a categorization based on its example as a retrovirus. And then finally, we came up with HIV, which was what we've settled on, agreed across the United States through the World Nomenclature Association. And the reason why this is important is that we still didn't know what the virus looked like or what it was, but we knew something about it. And as the virus was then discovered by Gallo here and Luc Montagnier in France, we were able to identify its impact and understand it. So, excuse me a second, I've got to, okay. Okay, I hate when these things derail me. So here's what I want you to think about. Here we are with a virus that's sexually transmitted. It's affecting people who are having intimate sexual relationships with more than one partner. So multiple partners, or non-monogamy, non-single partner sexuality, was supposedly going to protect people unless somebody entered into a monogamous relationship, having had a partner before. And so we identified the notion that every person you sleep with, you're sleeping with all the people they've ever slept with before. Think about that as a slogan for prevention. Okay. And of course, it was taken in all sorts of different ways. Now, here is an example of what showed up in people's lives, the Kaposi sarcoma, which we see very little of today. And this was like the scarlet A that was beginning to appear on people's bodies. People were terrified and wearing clothing until it started appearing on people's faces, and people wouldn't go out of their houses. They became morbidly depressed. There was a high suicide rate of people who became infected and demonstrated these overt symptoms. It's fascinating that this particular part of the visual, which was mostly superficial at this time, really took over the imagination of the public. Now, in 1985, I was working at a place in Boston, as well as the hospital I was at, called the Gay and Lesbian Counseling Service. It was a community gay counseling center. And George Grady, who happened to be the Commissioner of Public Health in Massachusetts, who ran the state laboratory, came to us and said, we now have this test that can identify people who are infected. This was the beginning of the antibody testing time. And he said, we don't know what to do about it because we don't have any treatments. Would you develop a pre-test and a post-test counseling session so that we would know that people are ready and willing to get the results of their test? And we don't know what the impact of doing that would be. Will it curtail people's sexual behavior? Will it make them act out more? We just had so many different unknown questions. And so with my team, we developed these counseling questions. So people would get their blood drawn, having gone through it. Are you sure you want to get your blood drawn? Then they would come back 2 weeks later when the test was available. And about a third of the people never came back for the results. That's how scary it was at that time. Once we had this test, the question was to test or not to test. That was the question. What did it mean to get a test result? Think about what you would do if you were given a test for something that you knew was untreatable, but gave you some sense of a timeline of your life. This is what people with Huntington's chorea have to face genetically when they come from a family where there's been a parent who's had Huntington's chorea. How many people get the test? How many people don't? Why? What's their motivation? So forth. So you can imagine these are complex questions. The photos you're seeing up here, Marcus Conant and Paul Volberding, were pioneers and colleagues of mine early on in the pandemic. Marcus was a dermatologist actually by training at San Francisco General, and was one of the people who started the initial treatments with interferon and other things with the Kaposi's lesions. Paul was an internist who had trained as an oncologist who became head of the AIDS program at San Francisco General. Paul later went on to be the chair of a committee that I was on from the Institute of Medicine looking at the future of HIV in the United States. This goes back about, it must be 10 or 15 years by now. And what we were trying to do is predict where we're going to be at in 10 or 15 years. Both of them are incredibly wonderful people and really brought to the typical medical establishment that it wasn't just gay people that had to be concerned about this. We owe a lot of gratitude to our non-gay physician friends who really said, this is everybody's concern. And I have always treasured my relationships with them. Okay, where are we? As you can tell, a lot of stuff was happening in the public eye. This is Keith Haring's initial discussion about ignorance and fear. And I'm going to show you a couple of different things that show you that this stimulated tremendous amounts of artistic and creative ways of trying to understand this pandemic. I find this to be one of the most endearing, loving things. And what it shows us is that art sometimes imitates life, as opposed to life sometimes imitating art. Again, this is what we were going through. In the 80s, people were fighting to get testing, to get treatments, to get the CDC to release information, to getting the FDA to release early trials of some agents. The single agent of AZT had been released finally and was helpful for some people for a short time. It turned out later when we discovered the action of it was not adequate to sustain suppression, that it made it a little bit worse for some people as well. It was very useful early on to prevent the neurocognitive changes. Now here, it's important for you as medical people to know that initially 20% of our patients who presented with HIV were cognitively impaired and became demented, 20%. That's how rapidly the virus was getting into the cerebral system. And so it was very critical that we were looking for agents that would slow that down. AZT seemed to forestall the dementia, and then unfortunately, when it stopped working, for many people, it didn't help at all, and in fact, may have made it progress even faster afterwards. So we moved on, trying to move from single agent therapy to double agent therapy, and we'll get to talking more about that. The rallies got bigger and bigger. People got angrier and angrier. All of the local foundations became political action groups. It was a way, as you can tell, it brought people together who otherwise would not have talked to each other. And it was quite moving in many ways. I can't count the number of vigils that we went through. This is the virus. Seems like a beautiful example of nature's design, like a porcupine that comes up against and you go, oh, they're beautiful quills, ouch. This virus, microscopic virus, really, once we found it, was the beginning of the looking for how do you stop it? What are each of these outcroppings, so to speak, on the viral core and finally surface antigens? What did that mean in terms of what we could do going forward? The public was beginning to wonder, is it just gay people? Who is staying in the closet? You all may or may not know who this is because he's much older than most of you are. This is Rock Hudson. He was the idol of all the heterosexual women of the United States at one point. He and Doris Day had movie after movie where they represented the idyllic heterosexual couple. And he was not known at that time to be gay. He came out as a gay man after he developed AIDS, developed actually an institute that he gave money to. And this is where he was just prior to where he died. This is not many years later. You can see this was a devastating illness to people whose livelihood was based on the public perception of them. Here's another hero I want you to know about, C. Everett Koop on the right. He was the Surgeon General of the United States appointed by Ronald Reagan. And nobody expected Koop to be the Surgeon General he turned out to be. He was a pediatric surgeon. He turned out to be the most scientific and unprejudiced man you could imagine. and basically said, we have got to deal with this as a medical illness. We cannot allow politics or prejudice to get in the way. And he was really amazing in how he stood up for things. I got to meet him a few times at various AIDS meetings, and it was really stunning how he thought about this disease as a scientist should. This is the AIDS quilt. Now, some of you, I'm sure, have seen this. This was on the Mall at Washington. That obviously is the Washington Monument there. Each of these panels represent one person who died of AIDS. And you can imagine this mall went on and on and on. Now, Cleve Jones, who was a San Francisco native, actually was the originator of this. When I was out in San Francisco in 1985 for a meeting, I ran into him. One thing I didn't say to you is that when I was an intern in San Francisco in 1980, I met the man who became my husband, and we began a relationship. And I dragged him back east for my residency, and he came willingly, just so we'll be clear about that. He and I left San Francisco in 1981, and within a few years had lost more than 50% of the friends we had there to AIDS. We actually went to the first AIDS quilt on the Mall in Washington and learned about many of our friends who we hadn't heard from in a while, couldn't contact, who had died of AIDS. That's how devastating this was. Fast forward to my generation now, is 50% of gay men were depleted by this disease. 50% of the gay men in my age category lost their lives to AIDS, because many of them died prior to when the triple therapy came out in 1995. The silence on this quilt was absolutely stunning. There was not a sound except for the occasional wailing, mothers who saw their sons, sometimes daughters, for the first time on the quilt. And we would walk around keeping a list of people, looking for people. It was devastating to communities. These are examples of some of the quilts. And pictures of people who died of AIDS that were put up on a wall because the people didn't have time to make a quilt. I want you to understand the emotional import of this, because when you're treating patients, this is background. This is the prologue to where people are living with this disease today. Those men who lived long enough to receive treatment in 1995 got in under the wire. And if I had a friend who died 3 weeks before the triple therapy came out, had he been able to live 3 more weeks, he'd still be coming over to my house for dinner. That's the emotional part of this. I really want you as physicians to understand it, and it means different things to different people, obviously. Anybody know who this one is? Ryan White. Ryan White was a young 15-year-old boy who had hemophilia, who got infected from blood products. Ronald Reagan called him the innocent victim of the AIDS epidemic. So I don't know how your mind works, but when I hear the word innocent, I then want to know who's guilty. If this is the innocent victim, that means that all the people who got it through sex or drugs are guilty. They don't deserve what? Our compassion, our humanity, our care. Ryan White went on to become a spokesperson for the pandemic. He died, unfortunately, when he was 18. And he became the moniker for the Ryan White bill, which has sustained programs throughout the United States that Senator Kennedy and Wellstone and others have really put their hearts and soul into. Ryan White was the innocent victim. so called by Ronald Reagan, who, by the way, it took 4,000 gay men to die of AIDS before he said it in public, before he said the word AIDS in public. And here, of course, was the ribbon that was then discovered to help in fundraising when people would walk around and show their support for the foundations. I'm going to read something to you which comes out of a book and tells you from the point of view of the individual. Paul Monette was a writer who wrote a book called Love Alone, an elegy to Roger, his husband. And I'm going to read this. I'm going to try to get through it without losing it, frankly, because it's a story of my generation. The story that endlessly eludes the decorum of the press is the death of a generation of gay men. What is written here is only one man's passing and one man's cry, a warrior, burying a warrior. May it fuel the fire of those on the front lines who mean to prevail, and of their friends who stand in the fire with them. We will not be bowed down or erased by this. I learned too well what it means to be a people, learned in the joy of my best friend, what all the meaningless pain and horror cannot take away. That all there is love. Pity us not. Paul went on to help fund some of the AIDS work of different local agencies. He died of AIDS about, I don't know how many years after his partner, Roger, died. I'm sure this face is familiar to some of you, Magic Johnson. Johnson had a very complicated history and experience with AIDS. He got infected, probably through heterosexual sex, denied it at first, then became symptomatic, couldn't deny it, and then told everybody he'd been cured. And so people went on saying, well, I guess straight people get cured and gay people don't. He finally acknowledged that he wasn't cured. When triple therapy had by this time had been coming out, he started to go on it. And as many of you know, although he had been quite impaired for a while, he was then back to playing basketball and became quite a national spokesperson in the sports field to help solve some of the prejudice that was there, which, by the way, is still quite prevalent. So this is a dose of pills in 1995 that someone took 3 times a day. This group of pills had to be taken 3 times a day in order to suppress the virus. Now, I don't know how many of you take any medication, but you know, this is you can get fat taking this many pills, just in terms of caloric intake. People who were, after a few months of doing this, people were missing doses. We actually knew that some people weren't taking their doses all the time. Women with kids, for instance, would take their morning dose before their kids got up. They wouldn't take their midday dose if their kids were home. And they took their nighttime dose when they went to bed, when the kids went to bed. And that's why there were so many people who, in spite of trying to take medication, had some treatment failures. Fortunately, over the next 10 years or so, we were able to distill this down to twice-a-day therapy and then combination pills. And as you know now, we're in a very different place where there even now an injection that one can take every 2 weeks. And there's some experimental long-term acting drugs going even further than that. But most people are on 1 pill a day of combination drug, depending on their viral strain, of course, and how effective it is for them. These pills have come to represent, though, what people have had to deal with through the course of their illness. Around the world, these pills were not available. Kids were dying, mothers were dying, whole communities decimated. The orphanages were growing so fast that this is what really most kids' lives were like. And many of them, infected at birth, died quickly afterwards or within a year or 2. this is still in the world a major illness. And it's just a matter of, can we get the materials to the people and help them take it? And just get rid of some of this incredible prejudice that is still there. So here's what we're going to focus on for a few minutes before we open it up to questions. And I'm going to really focus on what you all need to know, in addition to all the history that I've been telling you about and more. And I hope you'll read some about this on your own. So I like to think about HIV as a neuropsychiatric disease with systemic manifestations and significant psychosocial distress. That's a different spin on it than you probably have heard from internal medicine people or other docs, where they think about the mind and brain last and everything else first, you know. And I think it tells you a little bit about the very bias in medicine about psychiatry and about the mind. Most physicians are not trained to even assess cognition. Doing a thorough cognitive workup of patients is critical to knowing whether what you're telling them actually gets in. There were studies that showed that docs who were seeing patients and telling them how to take their HIV meds 3 minutes after leaving the office could not remember what their docs were supposed to be telling them or had told them. So we had to teach people to write them down. We had to send home booklets with, here's what you take, with pictures of with pills at what time would work. So we need to figure out what is the future of this as a neuropsychiatric disease. We're working on what's the meaning of neuroimaging now. You know, how much can we detect neurocognitive impairments based on imaging? Now it can document certain kinds of things that are very helpful to rule out, like toxoplasmosis in the brain, a cerebrovascular accident, cryptosporiosis, all these things that get into the brain. And now, as you've all heard about COVID, there is a long COVID, and there is some evidence brewing that COVID gets into the brain much in the same way and affects much of the same kinds of subcortical structures that affects HIV as well. HIV affects as well. So we need to understand what's the future of neuroimaging and how can we use it to help quantitate the degree of impairment. Stem cell work is being done, the use and thought about CRISPR changing genetic vulnerabilities. All of this is going to happen in your lifetime as physicians. This is an example of a scan showing some evidence. I don't know, can you see my pointer as I'm moving it? Yeah, okay. So you can see some evidence here. There's some widening of the sulci here. But this is a biopsychosocial world pandemic and requires us to put all of our efforts, both neuroimaging and prevention work and teaching, barefoot docs in the hinterlands to help patients take their medication. It's a comprehensive epidemic that needs a comprehensive solution. So we've had 27 plus years now of antiretroviral therapy. For most of you, you've grown up in an era where AIDS was changed from an acute to a chronic disease. I'll give you an example. I saw a man at the Fenway when I was there. I was working half-time at the Fenway for a while, which is a gay and lesbian health center in Boston. And I was treating a man for anxiety, depression, who had been a bodybuilder. He was about 6'2" and weighed about 215 pounds, all muscle, and became infected with HIV and started to waste away, literally wasted away down to about 130 pounds, right? Fortunately, triple therapy began. And within a year, he was back up to 200 pounds pressing weights and looked like the picture of health. He dodged the bullet and he survived, but not without some emotional and psychiatric consequences of having gone through that, thinking he was going to die. He started to use steroids to build up his body, which unfortunately complicated his cognition. He became a little manicky. I had to hospitalize him to make sure that he was safe. So these drugs have saved people's lives, and they've also made it more complicated for some. And then there are people who don't want to take it. They say, I've got this virus, let it take its course. You see, you're going to have to confront a very real values issue as physicians, which is that you think life is precious at any cost. You think that how long one lives or how well one lives is really what everybody should be searching for. So remember that there are patients who come to you whose lives have been a total wreck up until that moment. In fact, I had a patient who said getting AIDS was the best thing that ever happened to him. For the first time in his life, people would come show up his apartment, bring him food, take him to meetings. They would take him out to the movies. That he said, being sick has changed my life for the better. Imagine that. Think about how people would metabolize their illness in so many different ways. We need to think about where are we now with this triple therapy? We've gotten better and better. What's ahead? But we also need to think about, are there neuropsychiatric effects of treatment itself? Some of the drugs we know that we used at first that we no longer use caused a lot of impairment, a lot of depression, a lot of anxiety. And of course, we're asking people to take a drug for the rest of their life. We know that people who have the need to take medications, that the adherence rate can vary tremendously depending on the severity of the illness, the meaning of missing a dose, and so forth. But we also know that if people don't take their HIV meds on a regular basis, that they may develop viral resistant strains that they can then transmit to somebody who has not been infected. And even if someone is taking PrEP and then partners with someone who has a resistant strain to the drugs that are in PrEP, they can become sick and infected as well. People become tired of taking drugs, of going to doctor's appointments, of living with the uncertainty. Many of my patients, it took them 10 years on triple therapy to actually start to believe they would live, that they live a normal life. And we now have people alive for many, many years who are expecting to live longer. But lurking in the background when they see them in therapy, eventually many of them confess to this sense of living with borrowed time. And how do you do that? How do you make sense of that? We need, as I said, to look at the neuroimaging. We need to understand the brain as reservoir for HIV, how it gets into the CNS, and other mechanisms of neurodegeneration. This is all in constant study. I really ask you to start thinking about, can you find articles? I have a whole bunch of articles. If you want some specifically, email me and I'm happy to send you stuff. But, this continues to be an epidemic of the marginalized, minorities at risk, the poor, the sick with comorbid psychiatric disorders. And we now have ARVs, antiretroviral agencies, as prevention. By getting most people on antiretrovirals who are HIV positive, they will 99% not transmit the virus if they have undetectable virus. If we also have people on PrEP, which prevents the infection, we could eradicate this virus if we really had a concerted international program to get people on treatment and on prevention at the same time. We need to really think about substance use disorder treatment in all of its meaning of long-term care. You don't treat a chronic condition with intermittent episodic care. And we need to think about the impact of gender, race, inequality. And as physicians, you need to understand sort of both the value and benefit and limitations of psychopharmacology and psychotherapy. The therapeutic issues continue. I think that the really important thing is to figure out and get to know your individual patient and what's on their mind, even if you're only doing their psychiatric medication checkups. As you all know, medication has meaning for people, and you just can't ask about side effects. These are the things as a psychiatrist I deal with all the time. I'm not going to spend a lot of time on them because they're commonly known, but this all of what, as a physician, as a psychiatrist, we have to be prepared to work with our patients on. And I could go through all this in detail, but I think it would be more valuable for me to stop here and really use the 15 minutes that we have left to really get into what's on your minds, questions that you've had, and to move the conversation that way. If I'm going to stop sharing so that I can see more of your faces, if that's okay, because it's helpful for me to do that. Okay.
Thank you so much, Dr. Forstein, for that fantastic talk. I want to open the floor now to all of you for any questions. We didn't have any in the chat yet, but please feel free to put them in the chat if you're more comfortable that way. You can private message them to me too if you want me to read them out without other people seeing who you are asking the question. Or alternatively, you can feel free to unmute and go ahead and ask your question that way.
Hi, Dr. Forstein. Thank you so much for your touching and informative presentation. I have a question about lessons learned during the HIV pandemic, and if perhaps we've forgotten any with the COVID-19 pandemic.
Well, that's a great one. I mean, I could go on for hours just talking about how quickly we forget what is usable in one place to push to another. The biggest thing is, you know, how do we get people to take seriously what they're at risk for? And that's been a real problem. How do we deal with the deniers, the people who are scientist haters? I don't know how else to say it. You know, we're in an epoch where truth somehow doesn't exist. And science doesn't always know what is true permanently, but it knows what we know at the moment. And the role of science is to continue to explore that so we get better and better. But I think there's a lot of psychosocial stuff that we've learned from AIDS that could be very valuable. How to deal with prevention, how to get people taking the vaccines, how to distance themselves, how to take care of their grandparents, their parents, their kids. You know, people are being incredibly selfish about this in a way that we got around some of that in the AIDS epidemic once we were able to really be honest with people about sex. You had to be very specific about how you transmitted it sexually. You couldn't walk around the terms. You had to be able to talk openly about anal sex and oral sex and the difference in their risk factors and all that. I mean, I could go on, but there are other hands, so I see.
Thank you.
Yeah, Ibrahim, would you like to ask your question? I see you have your hand up.
Hi, yes, thank you. Hey, hello, everyone. First of all, I want to thank you for that presentation and just want to introduce myself. I'm Ibrahim Radi. I'm a last year medical student in Guatemala City. So my questions for you are, so my first question is, how do you think PrEP has impacted modern day views on HIV? And I'm asking this because PrEP is a relatively new concept in Guatemala. Yeah. So a lot of people are reluctant to take PrEP. And on the other hand, PrEP users justify the use of PrEP to continue or increase high-risk behaviors.
So that's a really interesting question. First of all, I think PrEP has to be put out there as easy access, lots of education. You know, we used to think that if people were on PrEP, they would go out and they would have a lot more sex. But data doesn't support that. People who take PrEP don't want to get infected. We have to tell people PrEP is really useful. Nothing's 100%. What level of risk are you willing to take as a human being? Do you get into your car without wearing seatbelts? Some do, in spite of the higher risk of dying in a car accident. So we have to be honest about risk versus, I never believed in the notion of safe sex. You know, for thousands of years, women died in childbirth, sex was not safe. Our job is to make things safer. Our job is to teach people how to think for themselves. When you take PrEP, it's like taking a pill, like a vitamin, to prevent something from happening. It doesn't necessarily protect you from illness or death, but it helps. And then you have to think, what is it telling you about what you want, what your desires mean? There are people whose sexuality is out of their control. That's a very small number of people who have a different level of concern for us in psychiatry. But the vast majority of people, in my experience, don't necessarily increase their sexual behavior. They're more conscious of it. But that also varies from generation to generation too, perhaps. Ariane, I see you popped up.
Oh, yes, I have a question, although it looks like Victoria had a question before me as well.
Okay, I'll take both of them.
Yeah, I can read out loud Victoria's question because it came in first. But Ariane, there's one question before yours after that, but I'll make sure we get to all of them. So Victoria's question is, how can we use the lessons of rapid antigen-based at-home testing for HIV to improve public health with COVID?
So as you all know, the problem with antigen testing with COVID is, and antibody testing, antigen testing tells us if people are currently dealing with the virus. The antibody testing doesn't really tell us whether you're protected or not, since we know that antibodies produced by COVID, just like antibodies produced by HIV, didn't protect people from getting infected. So we need to separate out protection from information and actually talk about that as two different concepts that people can be aware of. And we need to make all of this testing available. We need to understand the limitations of the testing themselves. You know, the HIV test is an extremely sensitive and specific test. So we were able to really use it to tell people, no, you're not infected once the antigen testing came out. It was a little more difficult with antibody testing, and that's why we did the Western blot confirmatory testing. I don't know as much about the details, the science of the antibody antigen testing for COVID. Haven't been able to stay up on all of that. So it's a great thing for some of you to think about, learning more about and reporting back to the group.
And I got another question. This was an anonymous one. It reads as follows. Especially as you have had such a personal experience with loss of loved ones and are also co-editing a book on loss and grief, I'm interested to know, how do you, as a physician and confidant to your patients, give yourself closure when a patient has passed or passes on?
What a wonderful question. And there is no single way that people grieve. Be prepared as a clinical provider that you're human. You cannot leave your humanity at the door when you see patients. And they will stir you up in ways that require you to pay attention to yourself, to find people you can talk openly with about it. I was fortunate before my husband passed 4 years ago that as a clinical psychologist, he and I could share all of this with each other. When our friends died, we had each other. We had our friends here in Boston to talk about these people with. I now have people, colleagues that I talk about, patients who are dying or have died. And I think we can't pretend that these don't affect us. There's no single way for people to grieve, and there's no time frame. You know, Elizabeth Kubler-Ross wrote a book on death and dying years ago and outlined 5 stages of death and dying. And it was wonderful that she brought death and dying into the public eye. Unfortunately, so many people got so hooked up on the 5 stages that when they went from stage 1 to stage 4, they felt like they had done something wrong by missing stage 2 and 3. Life isn't that clean. You know, we all process things differently. Grief is something I find myself periodically walking through the woods, thinking about a patient from 25 years ago. Patients who, you know, each of them take a few neurons in my brain. That's theirs for life. Just as I'm in their brain for life. We are not dispensable to our patients. And so when we lose a patient, we have to own that grief. You know, I even grieve patients I didn't like working with, right? Which is another thing you have to own, that there are difficult patients for some of you. And what's difficult for me might not be difficult for you. We all have our personalities and we all have to be honest with ourselves about that. But grief is a beast. It takes time. It takes being honest with yourself. Why am I so upset about this patient dying? Am I wondering, did I do enough? When we lose somebody who's not a patient, someone close to us, we always ask the question, did I love them enough? Did they know it? And there's no answer for that, right? But we have to be willing to ask the question and understand the question is an attempt to make peace with the loss that we don't have control over. In editing this book on loss and writing my own piece of it, I have learned that grief is a lifetime event. Loss is irrevocable. Loss happens. It's an event. Grief is how we process that over and over time. And patients come back to me, people I've lost from 25 years ago. Just this morning, I was talking to somebody, and one of my husband's closest friends from childhood is coming to visit. And I know that we'll spend time talking about all the friends in San Francisco we lost. Not a done deal. It's part of who we are. And you have to be strong with your patients. And there's no shame in crying with a patient when you're sad or they're sad. Okay. And then you talk about it. What was it like that I was emotional with you? Okay. That's the joy of being a psychiatrist. We get to talk about anything.
Dr. Forstein, thank you so much for that response, and I'm very sorry for your loss recently.
Thank you. I have learned more about my life, and I feel grateful. I feel gratitude.
That is admirable. I have another question here, and this is the one that Ariane was hoping to ask. Have you found yourself in situations with colleagues who hold biases against patients with HIV? And what is your advice for navigating those situations?
Great question. And yes, you will find people. There will always be people, colleagues who have something that they don't agree with you on, whether it's politics or culture or this or that. You have to say who you are. Let them say who they are. And find common ground that doesn't require you to fix each other. I have found that people are more open to thinking about what I think when I share what I think and not trying to make them think what I think. Does that make sense? In other words, gee, I don't think the way you do about this. Here's what I think, and this is why I think the way I do. I'm interested. Can you tell me more about why you think the way you do? Coming together when you're at opposite poles requires listening to each other, not just being angry about somebody having a different opinion. And frankly, our society today, our biggest challenge is that we have a schism that I hope is repairable. But I'm worried unless we teach each other how to listen.
Thanks so much. We have one last question here that has been asked anonymously, and I think it's an important one. And it reads as follows. Since data has shown that Black/minoritized communities are disproportionately impacted by HIV/AIDS, how do we as providers advocate for minority patients and address this issue while dealing with the stigmas and culture biases within Black/minority communities, while acknowledging the racism that also exists within the LGBTQIA+ community as well?
Each of you can only do what you can do as an individual. First, do an inventory of your own feelings. I have become, my husband was African-American, and so I was schooled for 38 years in my own racial prejudice that I grew up with, not thinking I had any. And he was an expert at teaching me what I needed to learn. And I'm grateful for that. But I had to own some of that stuff before I could go anywhere with it. And I think each of us has to sit down and do an inventory about what are my microaggressions that I am prone to? What do I believe about this or that? And where did I learn this stuff from? I'm really curious when people have a prejudiced view to ask, where do you think that feeling comes from? What was it like for you as a child? Recently I realized that my ending up with a man of color was not an accident, given that I grew up in Queens, New York, where my friends were multiracial and multicultural. And I never thought much about it. We were the posse. We went to school together, we ate lunch together. And, at that point in my childhood, before the age of 9, the concept of racism wasn't even a conscious cognitive frame, but it was there. It was part of who I was. And so I grew up in a world which was very racist, very homophobic. And as a gay man coming out much earlier than a lot of people did, I'm also a gay father. My husband and I adopted 2 boys, both multicultural, racial. And, we've worked very hard to pay attention to how to make the world safer for them. And in doing so, have figured out where we are taking issue with ourselves around what we believe. So I think just asking yourselves those questions is the starting point, frankly. I'm looking around all these faces and I can only see half of you at a time. I'm encouraged that this is what medicine looks like. This is not what medicine looked like 30 years ago, 20 years ago. It's extraordinary to me. Just looking at you all, what the future can be. So your first goal, regardless of race, gender, sexual orientation, gender identity, be the best doctor you can be. When I decided to come back to Mass General, people knew that I was a gay man. They invited me back in spite of that. And one of my mentors in medical school said, just be the best doctor you can be, because they can't fault you on that as a marker for their prejudice, homophobia, or whatever. So all I'm asking you is, don't stop learning, be the best physician, psychiatrist you can be, always realize there's more to learn, and put in the time. This is the most important time during your residency in medical school, where you have people to whom you can turn to for help. But that process doesn't stop. When I left residency, I was in a peer supervision group for 15 years, and we talked about each other's patients and about each other and what our limitations were. And I found that extraordinarily helpful. So be great at what you do, be an open human being. Don't be afraid to be you. I don't know. I don't have the answer to these questions, by the way. I know our time is coming to an end.
Dr. Forstein, thank you so much for this fantastic talk. We're really grateful that we could host you as PsychSIGN, and hope we can host you in the future as well. To the attendees, thank you so much for
Absolutely.
attending the talk.
You guys keep me young, so keep.
I'm glad. So yeah, I want to be mindful of your time, but also I want to be mindful of the attendees, who I know a lot of you are scheduled for 5 to 6 p.m. sessions or EST.